Welcome to As a Woman, Fertility, Hormones, and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and I'm a board-certified OBGYN and REI. I'm a fertility doctor, and every single day I talk about your health, your body, your fertility, and your hormones so that you can understand your body better. The As a Woman podcast exists to help educate you in a safe and effective way. This is a way for you to absorb information that you need, understand your body better, advocate for yourself, and also share with friends. So family, friends, the world can help understand what you're going through. One of the things that I've always been very passionate on my social platforms about is educating you about your body and talking about testing and understanding your fertility at an earlier age. I have to admit, when I first started on Instagram in 2016, I was still in my fertility fellowship. I was about to graduate and I was getting to the place where honestly I felt like I said the same thing every single day. And on the other side of the table, so many people were just surprised at the information. And these were educated, smart, successful people who had starting a family or having a child on their family goals for as long as they can remember. Yet the information that I was telling them, basic facts about their body and what happens as you get older and what you should know if you want to get pregnant, it was brand new information. I have to admit, I don't see that as much anymore. And I totally attribute this to social media and a new take on taking ownership for your body. There was this narrative 5 years ago when I first tried to sell my fertility book into the world. If you didn't know, Balancing Act is a fertility doctor's guide to enhancing your fertility and understanding your body. The rights to the book have been acquired by Penguin, and I'm very, very excited to be working to get this project out to you because this is complicated and it takes often a very long time to fully be in the best place to understand how your body works. And I just think a book will be so effective. But 5 years ago, when I was trying to tell people the importance of this book, over and over again, I said, people don't want to talk about their fertility until they're ready to have a baby. This topic is too hard for women to want to be interested in. So paternalistic, I know. And that there was no market for a discussion about hormones and fertility to a younger generation. That is a wait and see, and I'm only going to address this if I have a problem. Isn't that so reflective of American medicine in general? We have such a reactive healthcare system. We wait until you have a problem and then you get medication to treat the problem and the problem gets diagnosed. And even though there's renewed energy and interest in preventative medicine, nobody's talking about it in the fertility space, or not many of us. And I'm honored to be a trusted voice, and I'm honored to talk about this. So today I'm diving into, should you test your fertility? And what does that really mean? What does it mean to test your fertility? I see more patients contacting me and interested in fertility testing at an earlier phase in their journey, and I love it so much. But a lot of people don't actually know what it means, and when should you be reaching out, and what does it entail? And that's really what I want to go over today, because we got to talk about the hard stuff. We have to talk about how your body works. And if you have, let's have a child as one of your life goals, I am a huge believer that the things you do now matter and that you deserve to set a plan for that goal, just like we do everything else. Would I have ever gotten into medical school if I hadn't set being a doctor as a goal? There were certain steps I had to do, certain things I prepared for, I educated myself. And having my kids is just as big. Honestly, it's more important than being a doctor. I always wanted to be a mom. I never doubted it. And when I faced my own infertility, so unprepared. I was so unprepared, and I was a physician. And you hear the same thing from female physicians and surgeons over and over. We know they have an increased rate of infertility and an increased rate of pregnancy loss. I believe it's because we wait longer, but also we don't take care of ourselves. So your entire world matters, and you deserve to know what you're getting into and prepare yourself. So we're going to dive into that today. But before we do, quick updates. My favorite episodes are your voicemail episodes. We have some of them coming out this summer, and I'm so excited. 657-229-3672 is the voicemail line. Again, 657-229-3672. Call and leave your voicemail. We also have a new freebie which we have made, which I'm so excited about. This is my TTC starter kit. So trying to conceive starter kit. Honestly, I should rename it the You Want to Have Babies One Day starter kit, because a lot of it goes into lifestyle and preparing your body the best, and that can be done years and years in advance. But that's a freebie. If you go to the website nataliecrawfordmd.com/newsletter, you can sign up for the weekly newsletter and you'll get access to the TTC starter kit. Also in the newsletter, I answer some of your fertility questions, share some of my favorite healthy recipes, and just general updates to get to know you guys better. And we have a lot of exciting things coming to our newsletter community as we start preparing for the book launch. The other thing is that every single week I answer some of your questions at the end of the episode. These are my For Fertility's Sake FFS episode Q&A. These questions actually are asked on Instagram. So at nataliecrawfordmd on Monday, you'll see a question box. You can ask your question on Instagram. I will answer some on Instagram. We'll link to prior content if we have prior content. We also will answer some questions in the newsletter and then some here in the podcast episode. So stay tuned till the end of the episode to see what questions we answer this week. All right, friends, last huge thanks. Thanks for being here. Check out Instagram. You can also watch the YouTube at Natalie Crawford MD. It is completely different content, short form, fun videos. You can get a peek into my room. If you ever watch a YouTube video and then become a patient, you also know this is where I see patients. All right, let's dive in. In addition to seeing people at an earlier stage who are trying to prepare for their family journey, which I love, I'm also seeing people who want to have a bigger family. And this is very interesting. Probably 10 years ago when I just entered this field, standard 2 kids. Most people wanted 1 or 2 children. And now the vast majority of the patients I see, regardless of their age, want at least 3 children. Super great. I love kids. Let's have more of them. However, the more children you want, the earlier you need to start having them to decrease the chance of needing fertility intervention. And that's really interesting. If you want to have 4 kids, you really need to start in your mid-20s. If you want to have 2 kids, the magic age is 32, 33. If you're not starting your family by then, you're decreasing the odds that you're going to have that family size without having to go and see somebody like me. So I love that we're having discussions earlier to understand this. What I don't love is this narrative that I am healthy, so I won't have a problem, and it's okay for me to wait later. People absolutely get pregnant at older ages, but that's different. Adding to your family and somebody getting pregnant with a 2nd, 3rd, or 4th child when they're over age 40 versus trying to get pregnant with your first. And the probability of success is actually much different. Part of the reason is in people who've never conceived, there's some things that we don't know are functioning. And in people who have gotten pregnant, we know certain things work, especially if you're trying with the same partner. So always take a grain of salt when somebody says, well, my mom got pregnant at 41, my best friend got pregnant with twins at 40. These people, you don't know their full story. You don't know where they were in their family journey. So if we start with basic numbers, and then I'm going to get into what kind of testing we actually can do and what it means. Your odds of getting pregnant per month, that's called fecundability, and that is something that we can study, chance of a positive pregnancy test per month. Now, one problem we have in natural fertility research is that the outcome can be really different. Is it just a positive pregnancy test? Is it a clinical pregnancy on an ultrasound? Is it a live-born baby in your hands? But fecundability is the chance of a positive pregnancy test per month, and many people consider that the most finite measure of your fertility because that data is relatively easy, and if you look on a per cycle, not per month basis, we can have an understanding that as we get older, it is harder to get pregnant. So if your baseline is under age 30, most people have around a 25% chance of getting pregnant. If you're trying to get pregnant and you are between 30 to 33 and you're trying for your first baby, you have about a 19% chance per month, which is still pretty good. If you've already had a baby before, it's closer to 23, 25%, so really no different. If you're now 34, 37 and you're trying for your first baby, the chance of getting pregnant per month drops to 11 to 12%. If you are in the same age range but you've had a child before, it's 16 to 20%, so still improved. If you're trying to have your first child and you're 38, 39, it's 5% per month if this is your first baby, and it is 17% per month if you have had a child before. And if you're over age 40, it's 3% per month if it's your first. It's 9 to 10% per month if it's your second. So this is called parity if you've had previous children. And the reason why is that we know you successfully implanted an embryo, you ovulated, egg and sperm were able to fertilize in your body, your fallopian tubes were open. So there's some provenness to your fertility if you've had a prior child. If you've never had a child, this doubles down because your chance per month drops. You might have an underlying infertility that we don't know about. And at what age will you be? Realistically, even if you get pregnant today, when we go and add to your family, and what is the chance going to be then? And if you want to have 3 kids and you're 36, the math is hard. You have to gestate the baby, you have to get pregnant, gestate for 10 months, have the baby, recover. At minimum, that's going to be 6 months before you're ready to start this process again. So can you have children really close together, and does it happen? Yeah, I'm an example of this. But does it always happen? No. And secondary infertility is a thing. That means you had your first baby, totally fine, and now you're having an issue with your second. This discussion is going to focus on primary infertility. So you're trying to have your first baby and we're worried that you're going to have a hard time, but I'm going to throw in some secondary infertility at the end. So knowing that your chance of pregnancy is roughly 20% at age 30, we'll say 10 to 15% as you get closer to 35, and then 5% at 38, 39, 3% at 40. We sure would love to know if you potentially had an issue that would make it harder for you to get pregnant, and why. This is what all the people say you don't want to know. But I argue you might make a different decision. If you know you're going to go into early menopause, if you know your tubes are blocked, if you know you have a uterine septum, if you know your husband has no sperm, you might choose a different path than the standard approach of why don't you just try to get pregnant for a year and then come and see me if you have a problem. Knowing the information first might completely change what you do. And I know this because I've had patients in these shoes. And I think one of the reasons why we have this discussion now that we didn't 10 years ago is because egg and embryo freezing has gotten so much better. As the technology has improved, there's more that we can do and more that we understand about the body. Because if you are single at age 34, we can evaluate and have an honest discussion about egg freezing. And yes, it's expensive, but is it an investment in your future that maybe makes sense for your life goals? That's a you decision, not a me decision. But that discussion wasn't one that we could really have when egg freezing wasn't mainstream. So as it's not experimental anymore and success rates have improved dramatically, especially when done in a younger population, then I think this opens up a lot of different discussions and we have to start viewing fertility differently. So I consider the components of fertility testing. 1, are you running out of eggs? 2, are your periods regular? 3, do you have normal anatomy? 4, do you have sperm if you're in a relationship? Now, number 1 is going to be, how many eggs do you have? And this is one that has been very controversial, laying it out there, but I think is so informative. But you have to understand what this test is and what it is not, and how you approach it is really important. This is one that your OBGYN can start you off with, and it is a test to see what we call ovarian reserve. It's a blood test called AMH, or anti-Mullerian hormone. If you are new here, welcome. This is how I describe your ovaries. If you imagine that inside your ovaries is a vault where all your eggs are kept. When you are born, the vault is full. Throughout your life, eggs come out of the vault. Eggs actually come out of the vault every single month, from when you're born and on, actually before you're born, but regardless, every single month you have an entire group of eggs. Each egg grows inside a follicle. Well, all of those follicles, all of those eggs, they die every single month until you go through puberty. Puberty is the activation of the brain so that it matures and starts sending out a hormone called FSH, follicle stimulating hormone. FSH works to get a follicle to grow. It is a well-named hormone. As the follicle grows, the egg matures, makes estrogen, ovulates. The rest of the eggs die. The next month, another group comes out of the vault. You are on a preset pathway to lose eggs out of the vault no matter what. You can lose them faster. You might be able to slow down the pace. I believe you can. But you're going to run out. No matter what, it is going to happen. And all those months that you hadn't even started puberty, losing eggs. Any month you're on birth control pill. The birth control pill prevents your brain from sending out FSH. So you didn't ovulate, but you just lost them all, just like you did pre-puberty. Same for any contraception. When you're pregnant, you still lose eggs. When you're breastfeeding, you still lose eggs. So you're constantly losing them. We don't actually have a way to know exactly how many eggs are left in the vault, but what's really interesting is when the vault is more full, it sends out more eggs per month. And as the vault is less full, it sends out fewer eggs per month. So the more eggs you have inside, the more are going to come out every month. And the fewer eggs, the fewer. So we can check and see and evaluate the eggs outside the vault, and that is giving us an approximation for how many you have left. The two ways that you can evaluate how many eggs you have, one is an ultrasound. And with the ultrasound, we do a follicle count. You can actually see these small fluid-filled follicles, and this is called an AFC or an antral follicle count. We know what the average follicle count should be per your age. So if it's low, we're concerned that you are on a trajectory to run out of eggs sooner. The other test is a blood test, and this is called AMH or anti-Mullerian hormone. AMH is made from the granulosa cells, the cells that surround every follicle. So the more eggs you have in the vault, the more eggs come out every month. Therefore, you see more follicles on ultrasound, and there's more granulosa cells making more AMH. I like to think about AMH as living in your bloodstream a little bit longer. So let's say it reflects a few months of eggs, whereas an antral follicle count is reflecting 1 month in time. As you get older, you have less eggs in the vault, and less eggs are going to come out every single month, so you'll have a lower AFC and a lower AMH. Importantly, the body's not perfect, so there can be some month-to-month variability, and this is why I've even had people get an AMH done 1 year and then get it done a couple years later, and it's higher, and they think this test is bonkers. There's no way I have more eggs. But if you remember the test is just telling you about this month in time, then it can make sense. The truth is probably somewhere in between, and you're hovering around the same point, so that's not really different for me. Things that can cause you to run out of eggs early can be a genetic predisposition, a genetic disease, having some exposure your mom was exposed to when she was pregnant with you, probably being exposed to certain chemicals yourself, having endometriosis, having any autoimmune disease, ovarian surgery, cyst removal, or having chemotherapy in the past. And things that can temporarily make your egg count look lower are things that have chronically suppressed your ovaries because the follicles may not be as evident on ultrasound if you've not ovulated in a very long time, and the granulosa cells may not be as active. So the examples here are most notably recently being pregnant or breastfeeding. Number 2, continuous birth control pill use, especially if you've been using the pill for a really long time or continuously, so you're not even bleeding at all and your ovaries are getting no days away from the suppression. Potentially other forms of contraception if you have been not ovulating on them. So things like a Mirena IUD can be variable because most people actually still ovulate. Their ovaries are not suppressed, but they may not have a period due to progesterone impact on the endometrium, but other people don't ovulate at all. So if you have an IUD and you've been amenorrheic and had no ovulatory symptoms, you might still get sore breasts or know that you're ovulating. But if those ovaries have been suppressed, potentially that. So what we see is that when the ovaries haven't been used, you start to make less of the hormone. But we know that because if I pull you off the pill and check again 3 months later, it'll be different. To me, an AMH blood test is the lowest hanging fruit. There's age-related norms. We really like to see it over 1 for everybody. If you're around age 30, I like it to be 2 or higher. If you're 35, I like it to be 1.5 and higher. If you're 38, 39, 1 and higher. So it does change normally as you get older, but still it's reflective of how many eggs you have. Number 1, if it's low, you should get a further evaluation. See a fertility doctor, get a follicle count, talk about your family planning goals. I still check it even if you're on birth control pills, for example, because most of the time it comes back normal. So even if it's suppressed, you're fine. And if it comes back low, we can have this nuanced discussion because stopping birth control means you could get pregnant. And even though we're talking about your fertility as a future thing, we want you to be able to have a family when you want, and that also might include not now. AMH, low egg count, does not cause infertility. That's the common dogma. That's what studies have showed us. And I say this to patients too. Your body doesn't care if you have 20 eggs outside the vault or 5 eggs. You're going to ovulate 1 each month, so you have the same age-related fecundability, chance of pregnancy, as your peers, as long as everything else is normal. Well, asterisk, as long as everything else is normal. And double asterisk, but why? Why is it abnormal? And to me, you had ovarian torsion and had your ovary removed is a heck of a lot different than you have endometriosis or autoimmune disease, which we know they impact your fertility. So I always interpret this with a grain of caution and try to say, well, do we know why? Because that factor might impact us. More importantly, even if it may not impact your time to pregnancy, might it impact your timing of pregnancy? Meaning you might start now if you have a partner. If that were me, had I known when I was younger, I would have prioritized having a family, even if it was inconvenient because it was such a big life goal. I've also had patients do the opposite and say, okay, well, maybe my family needs to look different. Maybe I'm not going to have 4 kids and I need to start as soon as I can, but I got to get to this point first. So there's no right or wrong, but the point is that choice should be yours. You should have the information. And if it could be reflective of an underlying diseased state, don't you want to know that at an earlier age? And if you have less eggs, you're going to have a harder time getting pregnant with IVF or egg freezing as you get older. So doing those interventions younger drastically changes the outcome. And your egg quality is even more important if you don't have the quantity. Quality and quantity decrease as we get older. Quantity we can check, quality we cannot until you're going through IVF. Quality, a lot of the damage has been done when you're older because of your age. We all exhibit wear and tear of our bodies, and yes, you might be able to make an improvement on this based on your lifestyle factors. It might not be enough to get you where you need to go fast enough for the family you want to have. So doing these things younger, getting the opportunity younger is important. I love a follicle count. You'll see me do that all the time if it's normal. Sometimes if it's very normal, I don't even check AMH because it's so normal, we're good. But I really love both of them as testing how many eggs you have. That number does not mean that you won't have infertility. It doesn't tell you anything about your ability to get pregnant, but it is helping you understand your body, your timeline, and laying out the roadmap for some of your decisions. Unfortunately, no test will tell you that you can get pregnant until you try to get pregnant. Even doing IVF and having the most beautiful embryos in the lab doesn't mean you'll be able to get pregnant. So we have to accept that level of uncertainty when we're not yet ready to have our family. But knowing how many kids we want and if everything else is normal and having an honest discussion if freezing your eggs will help is important. If you want 2 kids, you're age 32, 33, and you're not ready to start your family, you should absolutely have a discussion about freezing your eggs. Whether you choose to do it is up to you. You should have the discussion. You should have your egg count checked. Now, whether you go on to the next 2 tests likely depends on where you are in your process of trying to get pregnant. One is anatomical. So this is checking the inside of the uterus and the fallopian tubes. Things can block your fallopian tubes: prior surgery, prior inflammatory disease, having a prior sexually transmitted infection, specifically gonorrhea, chlamydia, having endometriosis. Now, many people don't know they've ever had any of those. Many times, having tubal blockage is completely asymptomatic. Inside the uterus, you can have uterine polyps, uterine fibroids, and if they're inside the cavity, that can impact the ability for pregnancy to implant. You can also have uterine birth defects. Did you know that? Isn't that wild? The most common of which is called a septum. So the uterus is formed in 2 pieces. These horns elongate and fuse together. They become the upper 1/3 of the vagina, the cervix, uterus fallopian tubes, and Failure of this middle connecting portion to reabsorb completely leaves what's called a uterine septum. You have no idea you have this until we find it on ultrasound or you're undergoing a fertility or a pregnancy loss workup. Classic teaching is a uterine septum does not cause infertility, but it can cause recurrent pregnancy loss, up to an 80% chance of loss if a pregnancy tries to implant there. I would counter that we see them higher in an infertile population, so are we sure they don't cause infertility if they cause such a high pregnancy loss ratio? But either way, I live in the belief that if you find one, you should remove it. If you have a fibroid or a polyp on the inside of your uterine cavity, those often get you to us sooner because you might have bleeding, but most often those should be removed before you're ready to get pregnant. If your fallopian tubes are blocked, again, why? But also, that might mean you have to do IVF. And if you find that out, you might say, I'm going to freeze eggs now because I'm not ready for kids for 5 years, but my egg quality is better and my quantity is higher. So I'm going to freeze eggs now because I know I need IVF to get pregnant because of my tubal blockage from my crappy endometriosis. So now I can have the egg portion, the portion that's dependent on an age, already in the freezer, and make this journey a lot easier since I know I need to do IVF. Alternatively, you can just know IVF is in your future, but then you don't spend a year trying to get pregnant when it's not going to work. That test is a test of the inside of the uterus and the fallopian tubes. 3 options. One is an HSG, hysterosalpingogram. It's an X-ray dye test. Speculum goes in the vagina, catheter to the cervix. That feels like a pap smear. And then dye gets injected into the uterus and watched with ultrasound while the dye comes out the fallopian tubes. Second is a version of that, typically a bubble test or a saline bubble. It is an in-office evaluation. We call it a FIM view. This is where same part, speculum in vagina, catheter to cervix, water or saline gets injected into the uterus so you can see the inside of the uterus, and then bubbles have to go out the fallopian tubes. And then gold standard is surgery, like camera in the uterus, camera through the belly button, look around, push blue dye through the tubes. That is less often done unless you have infertility and some specific complaint, or they're doing surgery anyway, or you have terrible pain. Not something most people would do just for testing, especially if you don't have infertility. Those tests have to be done at a certain time of your cycle, so after you're done bleeding, but before the lining grows thick. For most people, that's days 6 to 10, or while you're on birth control pills. And then the last portion is a semen analysis. Every year, I have a handful of guys who have absolutely 0 sperm. Every year, I have a handful of guys who have very, very low sperm counts, IVF only. If your partner has no sperm, it's really frustrating to try to get pregnant for a year. Check pregnancy tests, have the monthly excitement, and you might need hormones, a surgical procedure, or it may not be an option. You might need donor sperm. It's really important for you to know this before you're emotionally drained from the process. Semen analysis is super easy, 2 to 3 days of abstinence, and check it. I want to make sure that if you're doing a test, you're doing one that has a full evaluation, concentration, motility, volume, morphology, or shape. I see a lot of direct-to-consumer products not having a morphology or a shape. You're not getting a full evaluation. Importantly, sperm changes every 3 months. They have such a short little life cycle. So all this testing now might be really different when you're ready to get pregnant in 5 years. But the question to you is, if something's off now, does it change your plan? And if it does, it's worth that information for most people. So I hope this helped you understand what fertility testing is and what it isn't, and have the right layout of perspective. I am going to answer a few of your questions. Remember, you can ask questions on the As a Woman voicemail at 657-229-3672, or you can ask Monday on Instagram at nataliecrawfordmd. All right, is there any harm in taking CoQ10 for males and females if we've been trying to get pregnant for 9 months? I actually recommend CoQ10 for both my male and female partners who are having infertility or having problems getting pregnant. It's considered a powerful antioxidant and helps mitochondrial function, and something that very, very low risk. So it is something that I add on for my patients. What is the likelihood that transferring a single embryo will result in twins? So for a frozen embryo transfer, we're typically doing a day 5 or 6 embryo called a blastocyst. This is already in day 5 or 6 of development. It is 1 embryo. But when you put it in, it divides after this. This means you would have identical twins, and the rate with IVF is about 2 to 3%, which is much higher than in the general population, where it's like 0.5%. So significantly higher, but overall still not common. Can primary ovarian failure lead to elevated cholesterol later due to lack of estrogen? If you go into ovarian failure earlier, you go through menopause, and if you're not replacing with hormones, then yes, earlier menopause is associated with a higher incidence of having cardiac disease later in life. And we know that when you go through menopause, there's a shift in what your cholesterol panel looks like. So most notably, you have a higher triglyceride level when you go through menopause, and that's considered one of the bad cholesterols. And you have a lower HDL, and HDL is your high density lipoprotein, but that's considered your good cholesterol. So yes, regardless of if you're going in early or late, once you've passed that menopausal transition, if you're not on estrogen, you see a shift towards a more male pattern of your lipid profile. So another reason why I absolutely recommend that patients are on estrogen replacement if you go through premature ovarian failure, premature ovarian insufficiency, if you run out of eggs early, the female body loves estrogen. It is so important to our hearts, our brains, our bones, our sexual health, our entire body. All right, friends, well, I hope you found this episode interesting and educational. Again, you can follow along on Instagram at nataliecrawfordmd. Ask your questions there on Monday. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And you can call the As a Woman voicemail at 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.